will be discussing about acute pancreatitis. Acute pancreatitis is acute inflammation of pancreas that may involve adjacent or remote tissues and organs. It is a common cause of severe abdominal pain and most frequent gastrointestinal cause for hospital admission. It can have variable morbidity and mortality depending on the severity of pancreatitis. There can be many causes of acute pancreatitis, but most importantly, they are the gallbladder calculi, pancreatic divisum, trauma, and of course alcoholism is a very big risk factor for acute pancreatitis. The diagnosis of acute pancreatitis is made by fulfilling two of the following three criteria. These are the typical abdominal pain, elevation of serum lipase and amylase activity, which is usually more than 3 times normal, and the characteristic imaging findings. So when the first two are present, there is no need of imaging just for the diagnosis of acute pancreatitis. The imaging of acute pancreatitis now moves around the Atlanta classification, which was introduced in 1992 and revised in 2012. It enables standardized reporting, which is helpful for communication between the clinicians and for research. It divides acute pancreatitis in 2 phases, early phase and late phase. It grades the severity of pancreatitis in mild, moderate and severe depending on the organ failure. It divides morphologically the pancreatitis in 2 types, edematous pancreatitis and necrotizing pancreatitis. Edematous pancreatitis is termed when pancreas is diffusely enlarged with homogeneous post-contrast enhancement, while necrotizing pancreatitis will have areas of non-enhancing parenchyma suggesting necrosis. This is how the edematous pancreatitis will look like. There is diffuse enlargement of pancreas which shows homogeneous post-contrast enhancement. There is some haziness of peripancreatic fat but no necrosis in pancreas or peripancreatic region. While in cases of necrotizing pancreatitis, there will be areas of non-enhancement in pancreatic parenchyma and peripancreatic fat. Sometimes the necrosis can only be in pancreas or only in peripancreatic fat, but most commonly it involves both of them. Atlanta classification also helps in giving the terms for the peripancreatic fluid collections. The collections which are seen in cases of acute interstitial pancreatitis, which are ill-defined in peripancreatic region, are termed as acute peripancreatic fluid collections. They are usually absorbed within a few days after the onset of pancreatitis. Rarely, these collections may persist, and if they persist for more than 4 weeks time, then they will be organized and then they are termed as the pancreatic pseudocyst. Remember, to term it as pseudocyst, they should be homogeneous fluid density collections without presence of any necrotic component or debris within it. While collections which are seen in cases of necrotizing pancreatitis, they are usually either involving pancreas or peripancreatic fat, but importantly they will be having areas of non-fluid like component within because of the debris and necrosis. These collections are termed as acute necrotic collections, and these collections are more likely to undergo complications like infection. When these collections persist for more than 4 weeks time, they are termed as vault of necrosis. Then they will be well formed, but still you will see presence of non-fluid like component within these collections suggesting necrosis and debris. This is one condition where MRI can help over CT scan. When CT fails to show presence of debris within the collection, MRI can show it better. So to summarize, Atlanta classification, it helps in differentiating the necrotizing pancreatitis from interstitial pancreatitis and also helps in denoting the different collections which are associated with pancreatitis.